Welcome to our second webinar. Our last webinar was looking at community empowerment approaches. This webinar is focusing specifically on health and well-being coaching, and I'm delighted to be able to say we're doing this in partnership with Help and Care, Primary Care Network, purely because of a huge amount of experience Help and Care have had in this area, developing this sort of service over a number of years. I'm today's chair. I'm the Executive Director of the Centre for Empowering People and Communities, which I'll say a bit about more. And I'm delighted to welcome also Mark Sharman, Chief Executive of Health and Care, Naomi Unwin, Service Development Manager, Gillian Brake, Health and Wellbeing Coach, Elaine Luck, Link Worker, and Andy Mintram, Business Manager from Adam Practice Poole Centre Primary Care Network. So a little bit of background, and I was thinking back to 1999 when Saving Lives, Our Healthier Nation put forward the idea of an expert patients program to help people manage their own illnesses and long-term conditions. In 2002, there was the launch of the first ever national self-management courses in the UK. And over the period of time I was running, over 100,000 participants went through those structured self-management courses, led by volunteers as well. At the same time, there's a huge interest in Europe around these sorts of approaches across our colleagues in other countries. And this led to the formation of a network on patient empowerment called UNOPE. And just thinking across the wider European context, mentioned in Europe because CEmPaC is a European organization, is that in 2012, there's a first European Congress on Patient Empowerment organized by the Danish presidency as part of the European Union Council with the WHO. And that brought together all the chief medical officers across Europe to really debate the whole concept of patient empowerment, self-management, health literacy, etc., and really started to put it on the map in terms of much wider European policy, and kicked off quite a number of projects across Europe. And following that, a range of European projects really highlighting the benefit of empowerment approaches, looking at the evidence, looking at how these programs are rolled out. In 2018, the Centre for Empowering People and Communities was formed to take forward the work of the UNOPE network. Were funded by the Robert Bosch Stiftung, which is similar sort of organisation to the Health Foundation. So we are not for profit. Our role, our mission is to identify best practice, share it and spread it, and share the learning, and ensure that people can really learn from each other and take things forward. And going back to the UK, in 2019, we had the universal model of personalised care, which really recognised the key role of health coaching in supporting people to gain the confidence, knowledge and skills to manage their long-term health conditions on a day-to-day basis. It's worth considering why all of this is important. I use this slide a lot. We know that when we look at health outcomes across the board, only about 20% of health outcomes are down to clinical care. The rest are down to our health behaviours, our physical environment, social and economic factors, and a whole range of things, some of which are within our individual control, some of which are outside of our individual control. But what we know is absolutely key to be able to manage that other 80% requires people to have the support and to move to the place where they've got the skills to be able to manage their health and long-term conditions and well-being on a day-to-day basis. And that's not learned overnight. Some people are struggling with low mood and depression and low self-confidence. And the role of a health coach is absolutely critical in supporting people on that journey from very low self-confidence or low health literacy activation, whichever concept you want to use, through to a point where they feel confident and much able to manage. And this is really essential to making the most of a 20% of clinical care as well, is the ability of the empowered, informed individual person to engage with trained and receptive healthcare professionals, and ideally a system which supports that as well. Those 3 points of a triangle making up that sort of strategic approach. And again, the health and well-being coach is absolutely key in that. So it's sort of worth reflecting on that. We know the evidence base for health coaching is strong. It's one of the strongest evidence bases around sort of self-management interventions, along with structured self-management support as well. I'm really delighted to really hand over to Mark Sharman, Chief Executive of Health and Care, who's going to give a bit of an overview from Health and Care's organisation and introduce the organisation to you. So, Mark, over to you.
Thank you very much, Jim, and thanks for inviting us this afternoon, and thanks everyone for joining us. I just wanted to give a quick intro. Help and Care is a charity and social enterprise that's based in Dorset, operating mainly in Dorset as far as the services we're talking about this afternoon, but also we operate across central southern England for the last 35 years. I suppose the first question is why we got involved in this business in the first place. Like we talk about the 4 core values for Help and Care around social justice, innovation, collaboration, and personal. And actually, personalisation is very much within our DNA. And I think that actually what we're talking about this afternoon is about all 4 of those things. So our journey started on this where we were awarded a contract with the CCG in 2013 for health coaching in Dorset, which where we employed 5 health coaches, and that operated across the whole of Bournemouth, Poole and Dorset. And that service operated for 6 years until 2019. It was a real challenge, as in, I think probably it was ahead of its game, and the CCG in Dorset were probably ahead of the game, because it was a payment by activity contract, and as an organisation we lost a lot of money because no one referred to it, because no one actually got health coaching in that way. So there were really, really low referrals. As we were going along that journey, we asked the CCG if we could pilot co-location in one practice rather than just putting leaflets in boots of chemists and in practices and whatever. And actually, I think some of the learning of that, but that was about a relationship with one GP and one practice who actually got what health coaching could deliver for their patients and for their practice. And in a way, there was a sort of a key moment where there was one of the receptionists, a patient came in, sort of said, I don't know what to do with myself, I need an appointment with a GP, and she pointed that person to a health coach. That person got great outcomes. The GP was delighted and then spread the word, and then the service took off. And I think some of that is about learning, is about how you get your ambassadors on board about selling your story. So that led to the CCG recommissioning the Untitled Non-Clinical Health Coaching and Social Prescribing Service in December 18, which we were awarded after quite a lot of competition. So we awarded it in December for a start April 19. And then sort of a curveball came called the long-term plan in January, which introduced for DES, enhanced roles, PCNs, and our whole world changed from thinking that we were just going to have a contract with 15 health coaches and six link workers, social prescribers. Actually, our world changed. And I think, and also in a way, is that the long-term plan tipped the balance not away from health coaching, but to actually emphasise the role of social prescribing rather than health coaching, which was almost like the junior partner to our contract with the CCG. So we started on our journey. We had 18 PCNs, all of which were different. And actually, our learning early on was actually if you started working with PCNs thinking they were all the same, you've got a big learning curve. So this is something that we co-produced with one of the clinical directors from one of the PCNs. And this, in a way, is like our sort of model for how we deliver our health coaching within Dorset. And each PCN, in a way, takes this basic template around identification, access, service offers, evaluation tools, and impact, and personalises that offer for their locality. Just looking on the left, the thing that has really changed, and it was happening anyway, but the whole experience of COVID accelerated that, is that there's been a move away from reactive, as in referral from a practice, self-referral, to a real emphasis around proactive identification of patients particularly through population health management. And so saying like COVID accelerated that, whereby because what we were offering had to change, we ended up doing over 8,000 what we called wellness checks, which were from lists provided by GPs, and over 1,200 of those people we're providing ongoing support to. I just wanted to sort of just reflect on some of the lessons for me organisationally about how mobilising health coaching and social prescribing in Dorset has been. I think the first thing, as in this diagram tries to make clear, is actually you've got to make it simple for the system. If one of the GPs was saying he's got a integrated community and primary care support worker, a PCN link worker, a CCG link worker, a health coach, an advocate, a care coordinator, and he doesn't know who to refer to. So actually for us, one of the things is about making it really, really simple for people to actually just contact help and care, and then we will point people in the right direction of the most appropriate non-clinical support. So the second lesson would be is for actually really investing in relationships and building trust. And I think organisationally for us, that has been the greatest challenge, as in working with 18 PCNs, is that's 18 lots of relationship management. I think the next learning would be is actually moving from a problem focus to a solution focus. We've hit so many barriers along the way, but actually having that resolve to overcome them. I think the next one, in a way, is actually the power of stories. You can talk about impact and evaluation, all the rest of it, but actually what gets people on board for what you can offer is some of the stories, and hopefully we'll be sharing some of those later on this afternoon. The other one for me is and they use it in, stole it from, I think, the sort of the private market, is actually using what we call advocacy marketing, which is actually getting the people you're working with already to share with others the positive outcomes rather than trying to promote it yourself. And actually really invested hard in building a network of ambassadors, clinical directors, people like Andy later on, and actually their promotion of what you do is much more powerful than what we do ourselves. So finally for me, really, it's actually, for me as chief exec, is there might be all the business stuff going on, but the biggest focus really is about supporting your staff to be personal, courageous, creative, innovative with people. So I now hand you over to Naomi.
Thank you. I think to set the scene, the role of the health and wellbeing coach, it's all about the context that is so important to understand, and that's a concept that we spend a lot of time discussing and digging deep with our teams. This is a cultural shift that we're operating in, and it just doesn't happen overnight. As Mark just said, operating across 18 PCNs, it's really complex. And it's quite a bumpy road. So being tenacious, having a really can-do attitude, and being positive and solution-focused is absolutely at the core of what we hope to bring to the service. The role of the health and wellbeing coach it's simple. It's quite a simple model. It's not complicated. Normalising the person's situation is very much at the core, and it's absolutely person-centred. Good quality relationships that are genuine with all partners, go a long, long way. And those processes and systems underpin the success, but they do take a while. So how can this make a difference to patients? So, that non-clinical mix with the health and wellbeing coach coming into post. For us, it was the other way around. We had the health and wellbeing coaches in post, and then the link workers came in. Lots of questions. What's the difference? Who does what? And am I supposed to remember all of that? Because that's quite difficult when the concept is new and it's not really firmly embedded in the network. So we started to think about how can we make it simple for the networks that we're working with, and really, our sort of motto of no conversation is a wasted conversation. It's really at the core as well. There is a triage infographic that we'll show later on that will hopefully help. We do try to get everybody thinking about a particular person or a recent tricky conversation that they've had, to really help bring to life, those other non-clinical issues that perhaps would be helpful for a person to have a conversation with a non-clinical coach. In some instances, teams have come together and created an aid memoir that's just helped them as a sort of handy reference to, oh, I mustn't forget that there's the health and wellbeing coach down the corridor, or actually virtually, as may be the case now. So moving on to, you know, how can we ensure that all of the network team sort of understand the value and can help that momentum in embedding this new role in the system. And you know, as has been pointed out before by Mark, opportunities to share stories are really so important. Stories tend to stick with people, they really do. And that relationship building, whether it's face to face or virtually, is absolutely fundamental. So what we've done, and they've been different across those 18 PCNs, we've tried to identify those opportunities to have quick informal catch-up, sharing stories, feedback, perhaps a presence at a protected learning time, maybe huddles, those water cooler conversations that perhaps don't happen so much now, so they're more virtually through Teams, etc. You know, help people understand at every opportunity, keep them thinking, you know, how the coach can support their patients and what they bring to the offer. One of the things that we created was a guidance for a typical day of a health and wellbeing coach. It was really important to bring to life the importance of downtime for the person, for the coach. We looked at a schedule of 4 hourly slots, and also, something that worked really well was having an hour of sort of 10-minute conversation telephone calls with clients, where a GP perhaps was thinking, I think this patient might benefit from a health coach, but I'm not absolutely sure. So shall I book you in a 10-minute appointment to have a conversation with that person to find out more about it? That's worked really well. The other half of the day, the guidance was, you know, to do some work out in the community, pick up those referrals that, you know, perhaps they're not coming through the GP surgery, they're coming via other sources, and that has shifted now through COVID to those sort of proactive referrals. So that shift from some of it's reactive to also proactive is really starting to embed in the 18 PCNs across Dorset, which is really exciting. All of that sort of use of System 1, EMIS, templates, data, that's another webinar. It's hugely complicated, but there's significant progress and traction. And certainly so many of our team, or most of our team now, have remote access to systems, which is fabulous. You know, measuring impact, that's absolutely fundamental, but measuring impact for the person, not just for the system, is really important. So we do use the PAM. That's got a fabulous evidence base, and not only can really work with that one-to-one work with the health and wellbeing coach and the patient, the client, but also in terms of a primary care network, the stratification of patients, looking at really big data sets. It can help identify sort of what approach works best for them, whether it is a group intervention or one-to-one. We also use the short version of the Warwick Edinburgh. That's another really helpful outcome measurement tool that we found is really person-centered. Thinking about the contribution to a network's priorities, I think some of the examples that we're starting to work with, high intensity users is a patient sort of data set that feels really helpful as a starting point for contacting proactively, whether it is the health and wellbeing coach or whether it is the link worker as well. Shielding, patients that are shielding, living alone, mental health issues, etc. I think just to sort of summarise the importance of all our clinical partners and non-clinical partners understanding the issues. We really like to sort of keep it at the forefront of people's minds. So that sort of infographic on the left is really helpful. The other part of it is that triage model that is developing quite independently, depending on the core team makeup in the PCN, depending on the system access, and depending on their preferences. But really, what we're looking at is we're trying to maximise every opportunity for working in an integrated way. That helps build the confidence to the whole team of new ways of working, and most importantly, that we're all joined up with a person, and that's what we're all working towards.
Thank you very, very, very much, Naomi. And now what I want to do is hand over to Gillian, who's going to give her experience from a point of view of a health and wellbeing coach. Gillian.
Thank you very much. So I'm Gillian, I'm one of the health and wellbeing coaches, and it's a non-clinical offer. I'm just going to talk a little bit about really what the role is, and then go through some of the ways in which that's been helpful for clients. So it's a supportive role, and we're helping people to take those steps to improve physical and mental well-being. It's developing with the client and in helping to improve their knowledge and skills and confidence in areas. And building with the clients, it's a way of looking at how activated they are in their patient activation to hopefully improve quality of life and improve health outcomes. With the clients, we're going to be identifying also, what's important to them. The whole point of health and wellbeing coaching is working collaboratively, and that's very important when we're working with people either in the surgery or in secondary care, or if we're working, very closely with our link workers. So just to have a look at this model here, this is the Bio Psychosocial Model, and this is something that I certainly share with clients and talk about with them, because it's a way of helping them to identify what's actually really important for them. So we have the medical side of things, and sometimes that can be obvious in that the client might come with a long-term health condition, but actually sometimes it might not be. It might be that's not really on their mind, that's not what's important for them, and they're coming with perhaps some underlying emotional and mental health issues that are important for them, and that's really what we're going to be talking about with them. Other aspects that occur and have impact on day-to-day is the social aspect. And so dealing with clients from 18 to about 92 has been my experience, and that's either in a GP surgery or in the community. And working with these clients, using this model to initiate that first conversation to establish what's important for them. So the referrals are coming from all over. So self-referrals, those people who ring up with a single point of access through help and care. Maybe a leaflet was given to the client while they're a patient in hospital. Surgeries are often we get referrals from GPs and indeed other clinicians, nurses, or other clinicians in the area, or indeed non-clinical, so receptionists. So lots of people coming into referring for coaching, and at that level we don't necessarily know whether that's going to be something that they're looking for. So very much that first part is looking at what's going on for them, so either in the medical sense or how they're feeling about things, in the social aspects, day-to-day, all these day-to-day kind of issues that are affecting them. This is giving really an overview of what the journey would look like for a client, and very much kind of at the beginning it is about listening to their story. So listening to what's going on for them, what's brought them to the coaching. Maybe they don't know what coaching is, maybe just actually explaining what the service is and what it can offer. It is really important for them to hear that and think for themselves whether they're actually going to be wanting to take up some coaching, which is about change. It's really working with people to effect some change, some small steps in their life to make each day a little bit better than it was before and a little bit better tomorrow. So with that in mind, listening to their story and explaining what the service is a really important part. Alongside of that is also, you know, we actually kind of do a kind of small questionnaire with them, with clients, to have a look at how activated they are. And this patient activation measure will really give us a sense to be able to work with the client collaboratively so that we can actually find out kind of areas in which their knowledge or their confidence is really going to be helped to improve, and indeed skills. So this listening part is really important, and for the coach to be working effectively with the client, it's also listening to see whether coaching is for them, or indeed there might be another person or service that they need to be referred to. So if this service is what they're looking for, and we're moving on from the listening and being empathic and taking on board all of the issues that they're talking about, then we're going to be looking at, so what's important for them and what is it that they wish to change to enable their life to feel a bit better. So in terms of identifying, it's going back to the Bio Psychosocial Model and really kind of honing in on not what other people are saying is important for them. Having clients who perhaps come and say, actually, I'm here because my doctor says that I need to look at my diabetes. You know, my blood sugars are all over the place at the moment. And in that conversation, identifying actually what's important is about seeing some family members, or getting out and about a bit more, or just kind of like having a chance to speak about something that's on their mind. And so with that in mind, it's about helping them to identify what's important. So, and sometimes people will come and they might say, actually, I've got all of these different conditions, and it's not that one that's important. I can manage my pain, but what I'm finding is my routine and my pace is an issue. Or actually, I'm actually feeling quite lonely and I need to get out a bit more, or I need to kind of like think about how I'm having a conversation with my friends and explaining why I can't go out, why I can't be available. So the broad sense of people that come, we all kind of go through this process together. So we're listening, identifying what's important, and then we begin to have that conversation about expressing what's important, what they want to change, and setting some goals. So the goals might start off, someone might say, actually, I really would like to get a job, and that's a really great thing to do, but actually the small steps to get there. So it's encouraging and helping the client to look at, well, what's going to get you there? What small steps can we do, or can we collaborate and think about together that you might do tomorrow to help you get to where you want to be? So in setting goals, very much working with the client in a great deal of collaboration with them to enable them to become more skilled at actually setting goals. So for example, I would use, and there are lots of different tools to use, and we encourage that. I might use the SMART, very specific, measurable, achievable, realistic, time-bound goals, and working through that system in collaboration with the client, with what's important to them, enables them hopefully to get to a stage where they're able to self-manage and do that for themselves, because it's not about someone doing it to you. It's about actually being able to take that yourself and activate yourself to move in that way. It's in the setting of goals that sometimes we come across as health coaches, and we have to be mindful of this, that actually someone is perhaps not in that coaching conversation. That although they start off thinking that this is going to be something for them, it becomes a bit more obvious that actually coaching is not really what they're looking for at the moment. And that's a discussion that we would have with the clients to enable them to explore what is going to be important. So it might be after a couple of sessions that, well, perhaps coaching's not for you, but they haven't come to the wrong door, because there's another side, another part of a journey they can go on. And sometimes, and this is where I have used communicating quite closely with link workers in the area that I worked in, and actually saying, look, I've got this client, and with their permission, they've allowed me to speak to you and talk about really something very different that they're interested in. They're interested in getting out and about and actually getting back into the community, or very specifically they're looking at a housing issue or a benefit issue, and that's really what's coming out as for them to be important. And so at that stage, sometimes we can finish the coaching there for now, because we can pick it up later, and they might go off and have a few sessions with a link worker, and then they might come back with a different set of things that are important to them. So it's very much working with a link worker, with whoever that we need to kind of like get people to work with. So it might be another service, it might be another professional who's able to help them at that time. And this is really important when we're working with people with 1, 2 or more issues that are affecting their day-to-day life. So we're going through the process, and this is over 6 sessions. This is up to 6 sessions people are getting. So it's not just in one session. And also these sessions are maybe over several months. I often had clients for 4 to 5 months sometimes, going through different goals each time, whatever was important for them. And the follow-up, looking at barriers and what stopped them and what's going to help motivate them. So lots of encouragement, lots of motivation to enable them to see that even the small steps are going to make a difference to their life. And so we're going to be moving on to a link worker now, who's also been dealing quite a lot with lots of different clients. So that's it from me, and that's over now to Elaine.
Thank you, Gillian. That was excellent, and that was a beautiful introduction through into Elaine. And we thought, although the focus of this session is health and wellbeing coaching, but the crossover with social prescribing, the role of a link worker is so important that we really wanted to hear from a link worker. So Elaine, over to you.
Thank you. So yes, I'm Elaine. I'm a link worker in Poole Central in Dorset. To me, the link worker role really does what it says on the tin. It's the link between many different people, from the surgeries to the patient to the coach, to whatever possible non-clinical support may be needed or wanted. Link workers aren't experts. There's no way we could be in everything, but there are some roles of specialisms that are starting to be looked at. But they don't necessarily know the answer to every single question that's asked. And what I always say to the patients that I deal with is, if I don't know the answer, then it's my job to go and find out. Being a link worker is massively all about collaboration and communication. And one of the wonderful things about working with an organisation such as Help and Care is that I've got colleagues from so many different backgrounds with varied experience and knowledge, and they're always at the end of a call or an email or a video chat. As you can see from the slide, being a link worker, it's not just a simple singular pathway. There's a wide spectrum of social prescribing involved. It can be from simply signposting to very varied supported navigation. We can be asked to help with a myriad of requests, but all the pathways at certain times will have similar conversations, and then they can split off into different scenarios. The whole process is very person-centered, which, as mentioned on the slide, it's about finding out what matters to the person, what Gillian has said previously. It's that in the first and subsequent conversations, and that can change as the relationship builds and further conversations are had. It could be as simple as finding a volunteer to collect and deliver a prescription, or shopping to maybe a shielded person during coronavirus, of which there was a lot in my area because we've got a high population of elderly, to someone being isolated and lonely, or someone losing their job or having housing issues, which could lead to them not being able to feed themselves or their family. This can all lead to internal stress and people feeling unwell, which makes the importance of collaborating with the health coach and also members of the clinical team even more important. So it's my job to find out about the issues and to what matters to the person, and to work out who and how is best to help them. It won't necessarily be me that collects the prescription or does the shopping, although it has happened a couple of times. It won't be me that does the occupational health assessment, but it is down to me to build the relationship with community organisations, be it voluntary, government, social, to find the people that can and do those things. So from the slide, you can see that one of the joint areas is that we always look at what current support people have, and that's across the board, no matter what the situation or the issue might be. Friends, family, neighbours, churches, community groups, they're so important, and especially at the moment with the current situation. And having that support can very much change the situation that I'm working with. If there are gaps in that support, or it's non-existent, then I need to be able to find ways to fill that, basically. So, for example, if we were looking at isolation, loneliness, mental health, it could be one of our coaches that can help with that, or it could be that I would signpost to a local or a national support group. It could be online activities, but again, in my area, most people don't have a computer, let alone a smartphone. So online support didn't really work a lot of the time. That adds another interesting excuse me, twist to the solution. And obviously there's community groups, there's social groups that were running pre-COVID, and hopefully will come back again. I am still waiting for someone that I can go to my first knit and natter group with, but and although that might be said in jest, that could be a lifeline for somebody. That could be the only socialisation they have in their week. Looking down the right-hand side of the slide, I could be looking for support for carers struggling at home, looking after their loved ones. It could be adult social care and Department of Works and Pensions assessments to be arranged. It could be home equipment to be found and installed. But whatever we come up with, it's a joint identification process. The person I'm asked to help has to give consent and has to want to go down that route, which they don't, and that's just the way it is. There is a great deal of support out there for people, it's just finding it, and some of it can be pretty well hidden. So as said previously, by sort of all of us, it's about building relationships and collaborating. Different NHS networks use link workers in different ways. As it was mentioned before by Naomi, some may be more project focused, for example, looking at a particular population demographic in the area, or medical condition, or some are more reactive to everyday needs. And some may be moving towards a mix of those. Every network is different, which is what Mark said at the beginning. One of the main reasons for the existence of health coaches and link workers is to relieve clinical staff in the surgeries of having to provide that non-clinical help. Due to the decrease rather of things like community centres, many people don't know where to go to ask for help, so they turn to the surgery because that's who they trust. This takes time away from GPs, from nurses, from doing what they're actually trained to do, and they're spending time trying to work out where to find information for these patients on things like housing and NATA groups. As we can see on the left, and as Gillian previously mentioned, people can be referred to me and to her from a variety of sources, from the GP, from nursing teams, administrative teams, clinical pharmacists, single point of access at Help and Care, and also patients themselves can self-refer. These can come through System 1, the GP system that's in our network, or as appointments, online tasks. It could be telephone calls, it could be through a website, it could be email. Again, different networks have different referral processes. Some go direct to the individual link worker and coach. Some go through a triaging process whereby they're fed into one person or one group, and it's then apportioned out depending on geography or possible condition or number of staff available. The triage single point of access function can help the surgery staff because they've only got to remember one person or one group to send things to. They don't have to remember all the different link workers, the different coaches and that sort of thing. But it is a work in progress, and it's dependent on each network, each surgery, and there's no right or wrong way. I think GPs and nursing teams are under so much pressure, and they struggle to do their own jobs in times allotted to them. So having a link worker function and a health coach function can be of great use. We've got more time than the allotted 10 minutes to talk to the patient, to obtain the information, and for me to start to find a way forward. As I said before, whether it's simple signposting or whether it's more complex supported navigation. As I mentioned previously, there's a high volume of elderly in the network that I work in, and so I've had to form a good relationship with the enhanced care nursing team, and I've helped them with varying issues, such as a 93-year-old lady who was living independently but with daily carers coming in, but she had a massive rat infestation. The carers were starting to not want to visit due to their own safety, let alone hers. So if they stopped going to see that lady, who would have helped her? Who would have checked she was okay? Who would have helped her get washed and dressed every day? I've also recently been asked to help an 85-year-old lady who's estranged from her family. She's in the throes of not quite yet diagnosed dementia, but she thinks she eats and cooks herself a hot meal every day. But when enhanced care went in, there's no food in the fridge or the cupboards, and she doesn't know how to use the cooker or the microwave. And she's lost a significant amount of weight. I was also asked to help a gentleman in his 70s who has no phone, and he tries not to use electricity in his flat because after his rent is paid, he currently has £12 a week to live on. That's it. So it was my job to find these people some emergency food, to get input from adult social care, and keep in touch with the clinical team, with the enhanced care team and the patients, and obviously check out some pest control options. The people I deal with, they're not always elderly, and I'm currently helping a 50-year-old gentleman who lives in a privately rented flat, but his landlord hasn't done any repairs on it for years. And on top of that, he now has a load of motorbikes that zoom up and down past his building every single night, which causes him and his neighbours a lot of distress. He's gone out to try and speak to them, and he's threatened with violence. So, it can be very difficult situations, but these are things that happen daily. And my sort of final example from last week was a younger gentleman who's moved from another county into Dorset, and he can't read and write. He's got no idea what benefits he receives. He's got no idea where the money goes. He hasn't got anyone to read his letters because he used to go to a Citizens Advice drop-in centre, but they are currently not available due to COVID. And he can't do online forms, which he's routinely asked to do. So as you can imagine, all of these don't require just one person. They don't require just one solution, and they can be quite complex. It's not just one call to or from me is going to suffice. Sometimes it is, and I sometimes do get random things like a lady who had received her hearing aids in the post, but she couldn't put them together because she had arthritis in her hands. So that was a little bit quicker to solve. But the longer I do this job, the more I understand just how varied it is, and how I think, especially at the moment, it's very much needed. It's quite new to our network, and I do hope that the surgeries that I work for and the practices I work for are starting to feel the same with the link worker and the coach role. I do get some lovely feedback from the surgeries, which is fantastic. And Andy, who's our next speaker, is one of my practice managers, so I'm hoping that he agrees with that one. So thank you very much, and back to Jim and then to Andy.
Thank you, Gillian and Elaine. I think that really demonstrated beautifully how the role of a health coach supports a person on those early steps, identifying what's important, supporting them to build up their confidence and knowledge and skills, and also the role of a link worker in around sort of a real sort of practical help around how do you get advice on benefit, on housing, put your hearing aid together, all those examples gave. And they really illustrate how so much of what's going on in people's lives or impacting on their lives are outside of that day-to-day clinical care. They're actually sort of a much broader range of things. And you really sort of began to mention there the role of the enhanced care team, MDTs, multidisciplinary teams, etc., and what have you. So I really now want to sort of bring us on to Andy, who's a practice manager, because I know over the years of these services just how important the role of a practice manager is in ensuring that these roles are welcome and integrated and really seen as a key part of the primary care team. So Andy, over to you.
Thank you, Jim. I'm not going to repeat too much of what the team have explained about what they do, because I think they've done that absolutely brilliantly, but very much focus on how we've implemented things in the practice, our approach, and some of the challenges that we're facing. Obviously, we all acknowledge this is very early days for the PCN-DES, and especially with COVID impacting us all at the moment, that roles have had to adapt and learn very quickly. But just to start at the start, so Poole Central Primary Care Network is a network of 6 practices in the Poole area, 64,000 patients across 6 practices. 34,000 of those patients are in my practice, and the other 30,000 are split across the other 5. So straight away that brings some challenges in terms of allocation and equity, but we're working through those really constructively with the rest of the network. First of all, I guess, why did we choose to work with Help and Care? And Mark said at the outset, and others have said all the way through, whether it's with patients or with each other as service providers, that trust and relationships between our organisations is key. And that was very much the case in this instance. I'd met Mark previously, and we were aware of the work they were doing through the CCG contract before the PCN-DES was published. So we were already aware of the work they were doing and their track record in Dorset, and indeed the wider area that Help and Care operate in across the south with different services. And I think it's important to acknowledge that for some networks, for some practices, ownership of these roles is an issue and is a concern. There are many people in general practice who I understand are concerned about if they don't have ownership over delivering a service, and what will they get. And so that trust and relationship is really important. I know in some areas, practices and networks will have recruited their own link workers and health coaches, and that's fine. Whereas others, like in our case, have very much gone with an organisation like Help and Care. But I think what's really important for us was to acknowledge that the network DES and all the requirements that we have on us, even pre-COVID, there's a lot of demands on networks, on clinical directors, on managers, time and resources, and indeed headspace. So you might even have the time and the resources, but frankly, dealing with all the requirements in the PCN DES is quite a headache. So if you've got an organisation who are already doing this work, doing it well, and are presenting you with a package of here's how we can make things even better and easier for you, then it makes sense to look at that and work with them. Obviously, your local arrangements depend on other organisations that you have in your area and indeed skills you have in your practice. There are no practices where they've had healthcare assistants who previously worked in health coaching or vice versa. So you may want to take advantage of that. But at the end of the day, it's about getting the right people in the roles and working with organisations, whether it's the direct provider of the service or indeed other services in your area that can help achieve the outcomes, not just to tick a box, if you like. I think for me, it's really interesting to reflect on some of the slides that Gillian and Elaine were talking about in terms of personalised care, because for me, the relationship between a practice, a network, and its provider of link workers and health coaches is much like the relationship between a link worker and a health coach and a patient, in that you need to listen to what's needed in the area. Every area will have different needs. You know, we even within our network, we have different demographic and geographic issues that mean our patients need different things from our clinicians, and therefore we have different needs of our link workers and health coaches to help hopefully address some of those issues. You identify those issues, you set goals hopefully, and then you follow up. So it's quite interesting that the model ultimately of personal care and supporting patients is actually exactly the same model for implementing a service like this. So don't overcomplicate it. Have a think about it in those terms, and actually it can help you bring back to ultimately the good outcomes. I think the other thing for me that this really highlighted is that we as practices get bombarded with leaflets and information from organisations saying, we offer this service, we're a new charity, we're a third sector organisation who can help your patients. Please tell patients about us, please refer people to us. The honest, frank situation is we can't do that. We've never really been able to do that effectively, and GPs and our nurses and our reception teams are busy enough doing what they do without trying to also think about the 25 other organisations that have approached us this week to contact us. So this is where the link workers especially have been fantastic for us. Health coaching has been explained brilliantly, and I appreciate CEmPaC primarily focus on that, but the relationship between the two is really important, and more often than not, they will refer between them. So somebody who's referred to the link worker will often then perhaps be referred to the health coach because some of their underlying concerns are related to conditions, and vice versa. The health coach will help with living with conditions and thriving with conditions, but they will have other issues that the link worker can help them with. And I know there's been much national discussion about the term social prescriber, and I agree with much of the comment on that. I much prefer the link worker, although I think link hero would probably be slightly more appropriate given especially recent experiences with COVID and the work Elaine's done. So moving on a little bit, I think the other key thing in implementing any service like this is the simplicity of access for the practice, for the staff, for the reception teams, for the clinicians, anybody who wants and needs to know about this. And so as already highlighted, that single point of access is absolutely vital. How it works in your practice, how it works in your network will be up to you. We are all on system 1 in our network, and we have shared admin activated and a hub unit which is in the process of being set up. So hasn't been out without its trials and tribulations, but we're looking at making sure things can be simplified as much as possible, because something as simple as the GP not being able to find the right task group in system 1 can stop them using the service. So it's really important to, even if you have a single point of access, that very first way of accessing the team of help and care in our case is absolutely fundamental, because we all know that I think there's a stat around general website use that you generally decide if you like a website or can use it within the first 3 or 4 seconds of seeing it because of how you can find the first thing. And it's not that dissimilar for a GP or other member of staff trying to find access to your link worker or health coach. Make it as easy as possible to get access to them and for them to be able to refer. So working with the team, we've talked a lot about GPs and clinicians, but I think we actually need to start almost at the opposite end. Your reception and team and the admin and anybody who deals with patients as a first line by and large are going to know a lot of people who potentially could benefit from a health coach or a link worker. They're the ones that often get the story from Mrs. Miggins about how her day is going, how her week is going, and probably they call in or they phone the same time every week in many cases. So have a think about some of those frequent callers, frequent attenders who might benefit, who have needs, but they don't necessarily always articulate it to reception, but actually they have a need because they keep coming back to the practice even when they don't have anything clinical to refer to. Look at case studies. So early days you won't have many, but as you do pick up cases, and Elaine's summarised a lot of really great examples there, make sure the work that your link workers and your health coaches are doing is fed back into the practice at coffee time if need be. It doesn't have to be a formal meeting. Just drop in examples so that your GPs, your clinicians, your reception teams, PPG, understand what's happening, because most of them, let's be honest, won't be exposed to that work in much detail. They may refer something themselves, or they may be aware that one of their patients has been referred by somebody else, but a lot of the time they don't know what's gone on otherwise until either the patient comes back and says they have an issue, or actually suddenly they're not seeing them on a regular basis and wonder what's going on. So make sure you have that feedback mechanism in the practice so they understand what's going on, and importantly, if something's not working, either from the patient's point of view or from the practice point of view, you can address it. It doesn't mean everything's gone wrong or things have failed. It just means there's that continuous improvement required to keep looking at how you can improve things. I mentioned already about access. Try and remove as many barriers to access as possible. We know all too well in the NHS that sometimes you try to refer to somewhere and get told, no, it's not on this form. No, you didn't do it on a Wednesday. Something silly like that. So just think about removing as many of the barriers as possible as you can. So for us, that started off very much as simply saying, send a task to Elaine. And during COVID, we acted quite quickly to make sure Elaine, as our link worker, had access to a laptop with System 1 on. I know some areas of the country weren't lucky. Dorset, thankfully, we had laptops already in place with secure access through to the NHS network and System 1. So she could act as a gateway effectively for the link workers and other members of the team in help and care, but just make it as easy as possible. We still have challenges. We still have some practices in the network who struggle to find the right task group. And of course, hopefully most people are aware in practice that we do have the general practice appointment data requirements coming upon us, where we actually have to effectively count all the appointments. And I understand why, because we need to measure activity, and obviously the impact and investment fund, which is part of the PCN-DES, does require a certain amount of referrals to link workers, for example, to enable certain payments. But don't let that distract from ultimately focusing on the outcomes rather than just the activity. The other thing to bear in mind, as Elaine's already touched on, is just because you have a link worker doesn't mean they will know everything. The really key thing is to then, through the practice, also promote the link worker not just to your patients, but to other organisations that you work with or you see at meetings. So whether that's, in our case, housing associations or local charities, arts organisations, the kind of places and people who will have interactions with our patients and may often then be aware of patients' needs or concerns that they may not come to the practice. In many cases, they do come to their GP and confide in us, but actually in many cases, it might be their hairdresser or somebody else. So if you can build local community intelligence and support, it's also helping to take the onus away from primary care in helping those individuals to support themselves. So again, make those referral routes into the link workers and health coaches as easy as possible, and if possible, not even at all through a clinician or even a receptionist if your local provider can facilitate that. So I mentioned about measuring success. It really is important to look at outcomes, not activity. And that's why when we first set this up, we were quite keen not to suddenly put in a clinic on System 1 and allow people to get booked up. It depends on how you view it and how the role might evolve in your area. For the health coaches, I know that the team at Help and Care felt that for health coaches, it is better to have booked appointments because patients feel like that's more like an appointment. But for link workers, that initial conversation is often a lot more fluid. It doesn't feel like an appointment. It's just getting to know somebody. So we very much work on a task basis. Now, because of the GP appointment data requirements, we're going to have to move that across to measuring all that activity. But we don't want to take away from the fluidity of the system that we have currently. And it's about having trust in your partner, if it's a partner organisation or the employee, a link worker or health coach, to do the right thing. Because I know in some practices there's a real desire to get appointments in the appointment book, somewhere to put someone and some way to measure something really quickly. And that is understandable, especially in the current climate. We all want capacity to deal with things and to take it away from GPs. But we have to bear in mind, as much as we all have short-term pressures, these are long-term projects, and the success of them will only will depend heavily on embedding good systems, on building the trust and relationships that we talked about earlier, and the real rewards will come in the long term. Now, yes, of course, we have seen benefits in the short term because of COVID, and Elaine explained nicely all the ways she's been getting involved during COVID with liaison with local volunteer groups and pharmacy deliveries, etc. But we mustn't lose sight of the fact that the network DES, the funding that's attached to those roles, and possible recruitment of additional resource in the future, it all relies on long-term engagement and building trust and relationships. So don't be in too much of a rush just to fill appointments with these guys. Make sure they have the time to get to know your staff, your teams. If need be, just let them have a day where they just come in and meet staff and listen to phone calls and understand what the needs are in your area, or work with your maybe your community teams. If you've got a good relationship with your community provider, maybe they could go out with them or sit in their single point of access, for example, and get to know people and build those relationships, because that's how the referrals and like will come in due course. So we've not been without our problems. As I said, we have 6 practices, and it's fair to say in 6 practices we have, 40 odd GPs and probably therefore 80 opinions about things, as the old joke goes. But importantly, we've got regular meetings with the provider. We make sure we talk about what's going well, what's not going well, and work on a basis that we're all ultimately trying to do the best for each other, for our patients, and that if there are issues, we have to be open and honest with each other about it, not just therefore not use a service. I think in the NHS sometimes we're very good, in primary care, very good at thinking that's not really working at the moment, I won't use it. And actually we need to make sure that we talk to our providers or our employee if they're directly employed, and really explore that to make sure that it works for the long term. As I said, these roles are being invested in heavily nationally, and more will be available over the coming years according to our PCN ARRS budgets. So now's the time to get it right, not just to make use of it, if you see what I mean. Embrace it, work closely with people, build the trust, build the relationships. Don't be in too much of a rush, as much as you might want to get them on the ground and working and seeing patients, and hopefully you'll reap the rewards. Thanks, Jim.
Thanks, Andy. That was really, really useful. Thank you ever so much. A couple of questions. One from Vicky, and this was to you, Naomi, around, was there any reason why you decided to use the Warwick Edinburgh short version over the long version? Is there anything you want to say around that particular choice?
I think the reasoning behind it was because we use the PAM as a standard, and that's 13 questions, but we wanted to sort of personalise it a bit more and make it not so clinical. So the shorter version of the Warwick Edinburgh seemed to fit really nicely, and that's the rationale behind it, really.
Thanks, Naomi. Question from Jackie. Jackie's asking how you approach areas, communities and local peoples not usually engaged. So some of your sort of areas of a population who might not be regularly coming to the surgery, who are a bit more hidden. What sort of processes do you have in place around that, Mark?
I suppose for help and care, we've been going 35 years. Like when we started 35 years ago, we were about community engagement and community development. And I think that culture within the organisation is still really strong. So we do have a network not developed enough of people that actually do engagement with communities and trying to link that in, but also through other networks and other collaborators. We collaborate closely with Dorset Mental Health Forum, other voluntary organisations. Absolutely, and going back to the slide that I did with the sort of the pathway thing. The bit along the bottom was actually about building sustainable communities and that outreach, and not seeing it just as a pathway through general practice. And I know we are picking people up through libraries, through other networks and the like, and I don't think we're going to get hung up too much on PCNs and primary care, because actually you can deliver really great health outcomes by accessing people through different routes.
Thanks, Mark. And a question for Andy. We've talked almost predominantly, well, we have just talked about link workers, social prescribing, health and wellbeing coaches. Andy, do you have any thoughts around the care coordinator role which is coming in, and how that might work within your PCN?
Yes, is the short answer, but I think it's fair to say, being quite honest, it's not something I've personally had a huge amount of time to look at. I think from what I understand, there's quite a lot more flexibility and interpretation probably required with a care coordinator. This could be, by the sounds thing, something from an MDT coordinator with a very defined list of patients for a very defined clinical group, through to somebody coordinating and working with the likes of colleagues here at Help and Care. So it's taking admin away from people who might then be able to spend more time directly with patients. So I think my general view on all of these roles and on a lot of this kind of work is identify your need first in your area, with your patients, with your clinical workload, within your practice and network, and then look to see what roles could help support you with that. I think sometimes there's a rush to appoint roles because there is money there to do so, and there may be individuals who you've already identified or you're aware of that can offer something to your practice or to your network, without already really clearly identifying the work that needs to be done. So I think, in our case, for example, we'll have a conversation with Help and Care about, okay, how could care coordinators work with the teams who are already working? Or we already mentioned our enhanced care team. That's the name we've got for our nurses who work they're practice-based, but they were effectively working out in the community with housebound and other patients who aren't quite under the care of the community team. So I think it depends on where the need is really, and then look at how those roles can support that. And I think we often look to NHS England and others to tell us what roles can do, and I would sometimes challenge that back and say, well, let's see what we think they can do, and then there's that thing of do it first and ask permission later, within reason, obviously. So I think ultimately all these roles and everything we're talking about today is to help support practices, networks, communities, patients, not just to tick a box or to fit within a structure. So I would turn the question around and say, what do you need in your practice? Can a care coordinator help you with that based on the information we have available so far?
Thank you, Andy. And a question for Gillian. Have you had any clients that have become too attached to you during your work, and how have you managed this? And I guess this also leads into sort of some thoughts around sort of supervision and your own sort of support in your work. Could you say a little bit about that, Gillian?
So I think very much kind of like it's about boundaries. So I'm very boundaried, and we kind of like, that's how we go through our induction, and we train our coaches and link workers to have boundaries and have that in place. And so, over a short period of time, you are kind of like making a therapeutic relationship with the client, in that it's about enabling them, but you're walking alongside them. And I think that that's the kind of like place in which makes the better relationship. So it's not, if you were to notice things like that, I guess kind of we would encourage our health and wellbeing coaches to maybe speak to their supervisor. We have reflective practice in place, and I'm one of the reflective practitioners. And so people can go and speak to someone about how that is and how that might challenge them and the relationship that they can see building. But I guess kind of like it's about knowing what your place is and what you're actually doing. It's having that confidence that that although you're having a really good kind of connection with that client, you're looking, you're not enabling them to over-identify with yourself and to become reliant. This is a relationship which is up to 6 sessions and will have an ending. and very much we deal with kind of like what that is for each and individual client. So it's on an individual basis. The support is there for our coaches and our link workers and other staff in terms of reflective practice, which gives them a confidential space in which to discuss you know, issues that might be affecting them.
Thanks, Gillian. And a question, I think this is very much for Elaine. With so many support groups closing during the pandemic, and Elaine, I think the issues you mentioned around people not being online, not having smartphones, so all of this wonderful talk around putting everyone online and everything, you know, there are significant barriers to that. How do you see the future going forward around support groups and things?
Well, I think we're all hoping that, you know, at some point in the near future that those support groups can come back face to face. But I mean, at the moment there is a lot of support that, as we've said, online, but there's many people that don't or can't access that. So it's about talking to people and telling them that there's new ways. You know, there's a lot of telephone befriending at the moment. There's one-to-one befriending that many organisations are providing. There's group befriending. We've got a local organisation here that are fantastic, and you know, they're trying to do group befriending based on a subject area. It might be gardening or cooking or art or that sort of thing. So it's talking, as we said, to the patients, the clients, about where that social support might be, finding out what they have at the moment. You know, some of the churches are bringing back some of the face-to-face things. I've got a gentleman that I speak to, and he now has a member of his church come to see him once or twice a week. That's managed to start up again. We don't know how it's going to go. So part of it is just trying to stay on top of what information comes through, what is available, what isn't available, and somehow trying to bank a lot of that knowledge. I'm a bit of an old-fashioned girl. I've got a paper spreadsheet that is on my desk constantly, and I'm constantly updating it. We have these with the surgeries. We've also got databases with Help and Care, and just talking to each other. You know, I think the Help and Care staff, one of the benefits of going through this COVID process is that we're talking a lot to each other about what is available, because it is changing. It changes, you know, daily. So it's just about telling people and helping people understand that it isn't things are different at the moment. Hopefully we'll come back to other things. And one of the biggest thing that I hear from especially a lot of the elderly people, as I mentioned, you know, going to a knit and natter group for somebody might have been that one thing that they did a week that kept that social aspect of conversation going, and it's gone now, and a lot of people are struggling without that. But finding others to talk to them, we've got health champions at one of our surgeries, getting them involved, getting them to contact them, referring them to people like Age UK who are doing telephone befriending. It's just trying to keep moving forward, keeping positive, even though a lot of the stuff that used to be available isn't at the moment.
Okay, thanks, Elaine. I've got a question around sort of a wider sort of European view around health coaching. To what extent is this in other countries? Health coaching in the United States is a profession in its own right. You have to actually be registered. There's professional registration. I can certainly see a time in maybe 5 or 6 years' time where some of these roles become professionally registered in this country as well. In terms of wider Europe, Denmark, Holland, Germany, all have similar sort of initiatives, particularly focusing around issues such as loneliness and social isolation. That slide I showed earlier, there's a direct correlation between the amount they're socially connected and the quality of their health and early mortality. So there's a real recognition now across all healthcare systems that these sort of wider psychosocial issues are actually fundamental to addressing. So a lot of healthcare systems are now working with this, and we work with a number of organisations across Europe around supporting them in beginning to develop this. And it's just worth mentioning, I mean, while we're talking about Europe, and I completely forgot to mention this at the beginning, CEmPaC were hosted by the European Health Futures Forum, which is a huge sort of a network really looking ahead towards the future of healthcare, what it looks like going into the future, bringing thinkers together, and they're sort of key in helping in securing our funding from the Robert Bosch Foundation. So they are a key sponsor of ours and facilitator. A massive thank you to the panelists, to Help and Care. They've got a huge amount of experience developed over the last sort of 7 years or so. And I know that for a charity, how much risk they took on in the early days when payment was entirely by referral. If they didn't get a referral, they didn't get paid. And that's quite a big risk for a charity to take on, especially as when health coaching was being set up in Dorset then, no one had ever heard of it, really. It wasn't in any NHS policy, there weren't any funded roles or anything, so it was a forward-thinking CCG and Help and Care who are willing to jump in, take the risk and build it all up. So absolutely thank you to Mark and to the whole team.
Welcome to the Dorset Self-Management Service. Meet David. He's having a tough time. He's lost his job, lost his confidence, and he's feeling depressed. He doesn't know where to turn, so he makes an appointment with his GP. The GP listens and suggests David try the self-management service available through the surgery. She puts him in touch with the health and wellbeing coach who tells him all about it. David finds the sessions really useful. His life starts to get back on track and he starts to feel better. The next time he's in the surgery, he tells the front desk staff how useful it was and mentions he's also going to speak to the link worker about a few remaining issues. The link worker listens to what matters to David and gives suggestions of further information and community support. Things are really looking up for David. The Dorset Self-Management Service. No wrong door. No wasted conversation.